Our next speaker is Dr. Rebecca Cunningham, who's an Associate Chair of Research and Injury Center Director, Associate Chair for Research, Injury Center Director and Professor in the Department of Emergency Medicine at the University of Michigan Medical School, and Professor in the Department of Health, Behavior and Health Education at the University of Michigan School of Public Health. She has a distinguished career in researching intentional injury and substance use prevention, particularly of youth and young adult populations. Her focus of interventions in the emergency room has helped position the emergency department as a critical location for public health interventions, specifically for violence. There's quite a lot more of Rebecca's CV to read here, so I will skip that and say we're really pleased that she made it through the pickets and the strikes at the international airports, and when she arrived on Monday. I'm so pleased she made it here. Please make Rebecca most welcome.
Okay, perfect. Great. Just some logistics here. There we go. Great. Thank you so much, and thank you for the invitation to speak today. I'm so pleased to be here on your sunny shores and to have the opportunity to share some of our work. I'm going to speak today what we're all sort of calling e-health these days, what I'm calling technology and brief interventions in the clinical setting and in fast-paced clinical settings, focusing on emergency medicine. Take just a moment to thank some of my many collaborators over the years who have worked with us on these projects. I have nothing to disclose, but do want to mention our funding relationships through the studies that I'll talk about, which are largely NIH, NIAAA, the Alcohol Institute, and the Center for Disease Control. So a little bit of an overview today. I'm going to focus kind of on a map here of what we're going to talk about, setting the stage a little bit for why I'm interested in the relationship of alcohol and violence specifically, mostly with adolescents and emerging adults, which is what I'll talk about today. To take you through a little bit of a journey of our e-health and our technology-grounded interventions in our clinical settings, focusing on two of our major studies. One is the Safer Teens study, and the other is the Project UConnect study. And then we'll spend a few minutes talking about how technology is changing quickly and how we as researchers and public health practitioners, what we need to do with that to move along, to make the best of it. And then how finally we're going to take this research into e-health and actually get it into practice, and spend a few minutes talking about research to practice. So a little bit of background, as was mentioned, foundationally I'm an emergency physician by training, and so I come to all of my substance use work by virtue of the window of injury, with the leading causes of death among the youth that I'm treating in the age group of 15 to 24 being unintentional injury, suicide, and homicide. When I step back and realize how much of my medical practice I spent learning the valves of the heart and diseases for treatment for cancer, and then we get to my clinical practice where the youth that I'm seeing and treating and sending back out are more likely to die of these three causes than anything else, and we have done very little both to prepare our clinical setting and our physicians and our public health practitioners for what to do with this. I see we have similar problems across continents here in Australia with both suicide, injury, unintentional injury, poisoning, and of course assault and violence being leading causes of death here for your youth as well. I mention here also just dating violence so that we don't forget about it. When I talk about violence and in our interventions, I will be talking both about peer and dating violence, and I'll try to make the distinguishing comments about when I'm talking more about one than the other. We know from our studies in the United States that 10% of high school students are reporting some dating violence, victimization or aggression. In our UConnect sample that I'll talk about later, about 15% of the youth who are coming in through our emergency department for any cause, for any and all cause, are reporting some violence, victimization in their dating relationships. And here in Australia, your national data shows a little bit more, even about a third. So how does this come in with the intersection of substance use and alcohol? Well, of course, we know that alcohol is associated very closely with all three of these leading causes of death among our adolescents and our emerging adults, and this is how I come to this intersection in both my clinical practice and my research. Just to take a moment, when we think about alcohol and we think about violence together, we we often think about just the acute intoxication effects and how these are related and expect that, well, once intoxication happens, there's an impulse control relaxes, and that is really where we're finding the major relationship with aggression. But I want just to cue you for a minute to think about a few other ways that the alcohol and violence are related. So as we move through the journey today, you can think about them because they affect our interventions. Alcohol is certainly related, and other substances, to that acute intoxication effect with a loss of impulse control. But we know that alcohol and violence are related in two other ways temporally as well. Of course, they cluster like all problem behaviors. But we also know from our focus groups and from our work that youth are also purposely sometimes increasing their alcohol intake when they are planning to go on and know that they're going to have an altercation of some kind, both to give them a sort of liquid courage, as well as to maybe decrease how much it will hurt if they do get into a fight. So there is some planned intoxication along with the idea that a fight might really be coming along. The other thing that we find that is really important is that there's a portion of our youth that are involved that have an alcohol and violence relationship that's involved really with the substance use being after the violence. The youth that I'm going to talk about in the first part of our talk live in environments that are very violent, are experiencing a lot of violence in their life, and often are just medicating, drinking to cope with what they're seeing or the fights that they've been in after. And really violence isn't part of their pre-phase, it is part of their post-phase. So where should we think about violence and substance use prevention in our world? Well, I really advocate, although I will come eventually down to this healthcare road, we have to come about it from all avenues. We need to think about it in our school settings, obviously, is a place to do both violence and substance use prevention, and we must. We need to think about it in our neighborhoods, both from the addressing the physical and built environment, from alcohol outlet density, to better lighting in the streets, to stores and liquor stores and how they're interacting with adolescents, other community venues. And then also we must think about the healthcare setting. And here I'll come to talk for a few minutes about Safer Teens specifically, and one of our interventions where we focus on alcohol and violence together. So why the hospital setting? Well, we talked a minute ago that we must address it in all of these settings, but why the hospital setting? There's a lot to do in an emergency department, in an acute care setting. There's plenty to do. My colleagues really want nothing to do with most of this to start. They say we have a lot to do already. Well, for one, the reasons that I think the healthcare setting is one of those four locations where we must is because the ED, first of all, plus or minus the literature, is maybe a teachable moment, and we can go back and forth and argue about that. And there may be something to that time period where you're in the hospital, where you see and are thinking about your health, maybe a time where you're primed a little bit more to think about health and health consequences. Maybe. You can give me that or not give me that. But one of the other reasons, and is there a pointer here? Is there a pointer? Oh, that was not the pointer. That's
that one. Yeah.
That one? Okay, thank you. This school-based one, if we only focus on the schools and we don't have really a multi-pronged approach, we're going to miss a bunch of kids. Because as I'm going to talk about in a minute, our kids that are perhaps the at most risk aren't showing up in school. So they're either not there enough, or they're not paying attention enough, or their literacy rates aren't high enough, and they're not going to get the messages that everyone may need to be getting if we only focus on the school setting. And then my colleagues who are quickly trying to give me reasons why the emergency department and acute care setting is not the right place to do this will say, well, not the ER. What we really need to do is we can focus on the kids once they're admitted to the hospital. We have a couple days sometimes with them after trauma, and this is the time that we should focus. And I would agree we should do something with them while they're there. Those are the most severely injured, the 3% of youth that get admitted to the hospital for a trauma. And we should definitely do something with them when we're there. However, we'll miss 90% of the youth that are treated and released if we only do that. Youth in my world, if you come in for most assaults or a car crash or anything else, including stabbings and most shootings, you go home the same day from the emergency department 95% of the time. Very few people get admitted to the hospital anymore. So we will miss people that way. And then finally, many of our youth, the primary care setting, people say, not the emergency department, the primary care setting is the place that we need to do this. And I agree, we also need to do it in primary care where we're having well checkups and we're talking about our routine health, and absolutely adolescent health providers should do this. However, 16 and 18-year-olds are not going so much to primary care. They think they're a little bit too big for that young pediatrician doctor. They haven't yet engaged with their adult physician, and they're generally healthy. When they get sick with a sore throat or bad stomach cramps, they come to an urgent care or to the hospital. This is more so true for the boys than the girls, and we know that the boys are generally more at risk. The girls tend to stay a little bit more involved because they're involved in reproductive health, and so they're coming into their physician for reproductive health care. But the boys, not so much. So they're generally falling out of our standard health care practices, and we don't find a place to interact with them, which is why we wind up thinking about the emergency department, because that's where they're at, and so that's one of the places that we need to then catch them. So how can we overcome these barriers that my colleagues will very accurately put up and say, first of all, they're there for a sore throat and they're there for stomach cramps, and they're going to be really mad at me if I start talking to them about why they're using drugs or violence in their life. They're there for their foot pain, for goodness sake. What do you do in talking to them about violence? This isn't our place. I have other things to do. I don't have any time to screen. I'm busy. I have 10 patients in the queue and 40 patients in the waiting room, and this is not the thing that I can do. And really, what the most important one I think here is this one here, is emergency physicians and many acute care physicians. This is not the way we're trained. This is not the way we think. We don't know how to have these conversations in a sensitive way. I could give many very amusing examples of the wrong way to give them, which I myself would have been very guilty with for many years. And these wrong ways, these very judgmental finger-pointing ways of the young resident pointing over the stretcher of the teenager who's just crashed their car saying, "You're going to kill yourself, don't do this again," which we know doesn't work at all and is passed down from generation to generation of physician. So what to do? So my colleagues and I pondered this and our interest in public health and in substance use and violence interventions, knowing that at the time I was working in Flint, Michigan, which is like Detroit, a little mini urban New York or Chicago, leading the nation almost in homicide and fighting. The youth that I saw come in during that time were very likely to have a serious violence consequence in the next year following their visit. We very much wanted to do something. We knew that their violence is also very much tied to their substance use in many ways, for the ways that we talked about before. So what could we do? So we talked about what kind of prevention program could we do in this kind of acute care setting, knowing all these limitations that we just had before, knowing that youth go back out and are hard to find after. What could we do? So we settled on trying to build in a single session a intervention that would be prevention intervention that would address their violence, but certainly also needed to address their alcohol misuse, because we know we really can't address one without addressing the other. And that we would focus on both of those. We would try to develop one that could be delivered by a therapist. I always think that it's better to be talking to a live person, despite whatever we're going to say about e-health over the next 45 minutes. However, I'm very practical at heart, and I know that that's just not possible. I often have one social worker who's dedicated to the entire hospital, including holding the hands of the person whose son just died. But I often do not have someone to give a real live intervention. So we need to be practical. How else can we reach the rest of the people some of the time? We thought about computer options. This was about 2004, so I want you all to think where we were with technology, by the way, first of all, in 2004. And we'll get to that in a moment. Who should we screen? Well, we should try to help everybody all the time, and that's not possible. So who should we screen with our resources? We could just screen, and many brief interventions in the emergency department have focused just on the injured patient when they've come in. We know that that group has a higher rate specifically, often of their alcohol use, maybe are a little bit better primed. We could focus just on those that were intoxicated that day, and that was in their relation to their violence. That group sometimes is not that coherent to have a lot of conversations with, but it is possible. And they wait around a long time, 6-10 hours sometimes while they sober up, so it's possible. And then there's the medical group, and this is the group that my acute care colleagues will have the hardest time with, just because, again, they're there for belly pain or they're there for foot pain, or why are we talking about their alcohol and their violence? And it's because in our preliminary work, I realized that the 18-year-old who was here today for his sore throat, by the way, was here for last month when he got stabbed, right? And I know that the youth in the hospital that I was working with are going to cycle in about 3 times a year to my emergency department for one thing or another. And every one of those isn't going to be violence, but one of them over those 4 or 5 years may be. And maybe the other times while they're there for the other acute care things are the times that we can talk to them about what's going on in their life. But we also know we can't screen every single kid that comes in, because we don't have the resources for that to intervene with every single one just because they live in the neighborhood generally, although we did a little bit of that later on. So we decided that we would focus on kids who had any alcohol use at all. So because we wanted to do an intervention that had to do with substance use, they had to, legal age of drinking in the United States is 21. We wanted to focus on adolescents at a developmental time period that was roughly around high school, and look at youth that had said they had some engagement with alcohol and any past year fighting at all, no matter what level over the past year, and thought, let's see if we can engage with this group and see what happens. So we went ahead and developed a study that I'll talk a little bit more about now called Safer Teens. And in this study, we focused on screening with the criteria that I just talked about, alcohol use and past aggression in the past 6 months, this past year. We screened about 3,000 youth that came in over a 2.5-year period to my urban emergency department. 25% of those met those dual criteria, and the limiting factor was their alcohol use. It said 70% had fighting behaviors. This was an NIAAA funded study. It was an alcohol use criteria. If it had been a cannabis use criteria screen-in, 60% would have screened in. Of those, they almost all completed the baseline because they're there. I appreciated the talk yesterday in which how you get people to stay retained and actually do the interventions. We have the beautiful opportunity of we have a youth who knows they're going to be sitting around for the next 6 hours, either in my waiting room or in between x-rays or everything else, and you don't have to be that engaging to get them to do something. So, which is great because we're not that engaging. So we got, of them, 88% agreed to do our screening. They weren't that offended, even though they were there for their foot pain or their belly pain. They were happy to answer our questions for a dollar store gift of a fancy pen or some little hairspray or something that we gave them out of a gift basket. 88% then completed our baseline, and we randomized them into one of 3 groups with about 250 per group. A computer alone group where you were just going to get the computer and not get to talk to anybody else after that. A therapist group, which I will point out in a minute is not really just therapists, it's really computer-assisted therapist group, which I think is very important. And a control group, which is basically standard of care, plus a little brochure with some resources for the community and wishing you well, which is far more than you get on your standard visit to the emergency department for either your alcohol or your violence. And then we followed them for 3, 6, and 12 months, and we were able to retain them for those follow-ups. The design we just talked about, we had standard measures including attitudes and self-efficacy, and then behavioral measures of standard scores for audit and binge drinking, alcohol-related consequences on the posit, peer aggression and victimization, mostly on the conflict tactics scale, for those of you who are familiar with it, and violence-related consequences to mirror an alcohol consequence scale, so problems with the law, problems with school, problems with my family due to my fighting. So just to get back to the practical side again, because I find we spend time in research not thinking so much about the practical side. So exactly how do we screen people in a really busy clinical setting? What does that look like? So we did use, and again, this was this initial screen, and I'll walk you through a little bit like my last colleague up here, a timeline. So 2004, 2005, so we were a little bit pre-iPad. So we had tablet computers. They were touch with a pen at the time. Why use the computer screen is a little bit now of an obvious statement, but it does allow for the complex skip patterns. We need to be efficient if we're going to do things in a fast-paced medical setting. We need to figure out efficiencies, and the computer allows us to do that. It allows for data safety. Our literacy rates are pretty low, and we were very worried about this initially. Were people going to sit and do a long screen reading it? And so we have a button that the questions could be read to them that way. That spoke to our low literacy. And then there's the sensitive information that kids, especially youth, maybe they're a little bit more savvy now, 10 years later than they were then, but they'll really answer pretty much anything on a computer, and they'll do so with a lot of confidence around their confidentiality. So we got good disclosure rates. People often ask, well, are they really disclosing the behavior? And boy, if they're under-disclosing, we're really in trouble because they're disclosing a lot of very sensitive behaviors. A sample of our screening tablet then from Safer Teens with a touch point screen that would walk them through. The arrow there points to the audio button that they could turn on if they wanted the questions to be read to them. For the survey and the intervention, I'll say again and over, the tablet, on the tablet you'll see the youth, and this is a later version of it. This is the 2010 version, but on an iPad where they would go through and pick the questions with their hand. But the point here is that data doesn't just just dumped into an Excel sheet. That data is used in real time to be tailored and fed back to them in the intervention, both for the therapist and then for in the computer intervention. And this allows an efficiency that's really important in our setting. Because I need to get to an intervention that we can do. When we were brainstorming initially with my colleagues, how much time do we actually have to do an intervention? And we have about 30 minutes. I can get to 35. I'm not going to get any more time than that. And it has to be able to be stopped and started, and clinical care has to take precedence first. They have to be able to stop and go to x-ray. They have to stop when the nurse comes back in to give them their medicine for something. Anything you do for them has to be stopped and started. And we need to have efficiencies and some metrics for how we're going to keep track of that along the way. Clinical care has to be prominent and first for their acute care. Otherwise, my research altogether and all of our work will be rapidly kicked out of the emergency department. I just put this slide in to say that whether we're doing this kind of computer screening in settings with Wi-Fi or without Wi-Fi, so now we can do it in more Qualtrics or online formats, but you also still can do it in dead zones. EDs were often some of the last places to have good Wi-Fi. They keep us in the basement. They don't give us any lights. The walls are really thick. Often Wi-Fi is terrible, so you can also just have it kept on the computer and then uploaded when you can bring it back somewhere else. So what to do in terms of the intervention delivery? Again, it's computer or therapist delivered for Safer Teens intervention, and here are pictures of both of those. On the left, the youth will simply go through the screen, and then the intervention will pop on. They will have audio headphones on for privacy, and they can sit anywhere. They can sit in the hallway, in one of our hallway beds. That is when we're too busy to have people have their own rooms. They can sit in an individual bed. Their friends and family can't hear them, and we make it so their parents are not allowed to stand over their shoulder if their parents are there. Or the therapist will sit with them with the computer, and I'll go through that in a minute. The computer, again, we really have as being an assistant to the therapist. So the computer facilitates the intervention for the therapist. And the therapists in the room always get really mad at me when I say this. So yes, I'm very confident the therapist can do a great job without the computer before I offend everybody. But the problem we have is the ED setting is busy. So we have therapists who are trying to give a brief intervention. Well, on the other side of the curtain, a baby is screaming. And on the other side of the curtain, somebody's getting a cast put on. And by the way, somebody's getting taken back and forth to x-ray. So it's really great to have some prompts for the therapist that's there to keep them on track and to help them remember what it was to feed back to them that they gave them, that the patient said to them 15 minutes ago. Some of that is fed back by the survey format, and some of it is fed back by the computer itself, or they're checking. Just as you would check in an old-fashioned workbook as you went along, if you check reasons for something, if you and the participant together, on the computer, that's saved on the computer and then is fed back to them later on. So it's a nice aid. It's a clinical support aid for the therapist. It also helps with this fidelity part. We know brief interventions, once they're rolled into clinical settings, quickly lose their fidelity for lots of different reasons to the different components. Having it structured in the computer format allows them not to skip those parts. Now, it does limit a little bit of the free-flowing conversation, I think, that can happen, but I think the therapists are great and well-trained, and they learn how to work around that. So my one goal here certainly is never to eliminate the therapist is this role, but to get to an option for how we can manage brief interventions when there is no therapist available, and how to get to a standalone component. And I'll just say here, this part is really important. The computer intervention is not a passive thing that is delivered to the participant while they lay there and they watch it like TV. And we'll go through that a little bit in a minute, but it is interactive at every step. So what is the content? I think it's really important as we move to e-health to say over and over again that e-health and technology is a way to communicate, but is not the theory to communicate. And we have to have theory-driven technological interventions. And as we move to these new ways to communicate, we need to always bring it back to what is the theory underlying that communication. It's heavily tailored, as I mentioned. The beauty of both the computer therapists automatically tailor things. We do it in our head all the time. Our brain is amazing. The computer also needs to be heavily tailored because the individuals in front of them are very different, and it needs to be interactive. So the intervention content for Safer Teens, again, this violence and alcohol intervention, is based on an expert model, MI-based. We based initially on this model, partly alcohol screening and brief interventions are becoming reimbursable in Medicare and Medicaid, and we are hoping to move to a model someday, in my dream, where we can also reimburse a violence intervention. Many of you are familiar with an MI approach. I'll say only that the intervention components that we have here, many of you will look familiar in terms of an MI approach: agenda setting, going through goals, feedback around their alcohol and violence, discussion with them on reasons to stay away from drinking and fighting, a summarized session. That these are present in both the computer and the therapist component sessions in a parallel format. We also added in this part here, which is skill building. We realized that our youth, in terms of both their refusal skills for substance use, but also in terms of their fighting, they need some skill building on how to make a safer choice, some basic conflict resolution skills, and we go through scenarios with them. They get 5 scenarios. We have 20 developed. Which 5 they get is based on a tailoring format, based on gender and their risk. So you have kids that have had some drinking and are fighting every day. You have kids that are really involved in fighting, have already gotten shot once and are only drinking once in a while. You have girls that are more involved in dating violence and less involved in alcohol. There's a big spectrum that we're trying to reach here in terms of when we say an alcohol and violence intervention for multiple risk behavior, and to do that, we heavily tailor it. So which scenarios they get, either in the computer format or in the therapist format, are pre-generated and chosen for them based on their initial screening survey of the behaviors they're involved in. So for example, if they were involved in dating violence, then they got a dating violence scenario. If they were a girl, they got the girl one. If they were a boy, they got the boy one. And we went from there. If in the computer session, it was an animated role play with sessions where they made choices and it paused. And after it paused, they would then be showed the better choice or the safer choice. In keeping with the conversation yesterday at the eHealth symposium, we are focused on the positive imagery. So when we do role play a choice, we're role playing the positive behavior, not the negative consequence. This was our population in our initial study. And a few things to point out here quickly is 44% have failing grades and 10% had dropped out of school. These kids are not going to be well met by only a school-based population. They're heavily involved in violence in their life, and we were initially surprised to see that it wasn't mild violence that they were involved in on a conflict tactic scale. They're involved in severe violence that is likely to lead to harm. Some of the initial screens that the computer would walk through with them, either the therapist or the computer individually, some normative stat screens on where they fit in terms of their drinking. They would either go through on their own in a checklist, as I mentioned, reasons to stay out of fights. If it was them and the therapist would turn the computer towards them. They would check them on the screen, and then they would discuss it together. This is an example of I won't play this, the clip of a scenario if this is a refusal skill for alcohol around drinking. And again, if on the computer they would get this animated role play that set up the scene for them, and then they would make choices. In the therapist scenario, this wouldn't be there. They would just talk through the scenario. So what did we find from Safer Teens? We found that Safer Teens, this single session, it was a 35-minute intervention. It turned out about to be between the therapist and the therapist or the computer section. We decreased severe peer aggression both at 3 months and at 12 months, the therapist. So the therapist was very effective for this, the computer less so for this, the computer standalone. The therapist, however, when I go back to, remember, this is the therapist very much in conjunction with our standardized computer format. So this was the first time we had seen a brief intervention for violence affect reports of violence behavior over the subsequent year. We also had impacts on victimization, being that fighting at this age is very closely tied, and who is the victim and who is the aggressor in these early teen relationships often floats back and forth. The computer had some effect here on victimization. Again, we see stronger effects for the therapist. We impacted dating violence for the youth that were more involved in dating violence. If you had dating violence, moderate dating violence on a conflict tactic scale, more than 4 episodes or more than 8 episodes, the computer group alone did have some reduction in their dating violence victimization. For more severe types of violence, the computer was not quite able to get at that, but the therapist did a good job and was able to impact that behavior. In terms of their substance use, we see glimmers here for the first time that we can have a standalone computer intervention that impacts alcohol consequences at 6 months. Both the therapist and the computer did this. Those effects in this intervention were not sustained to 12 months, and we did not see them at 3 months. We did not see impacts on binge drinking or alcohol misuse. This population in particular, overall, alcohol is also not the drug of choice, and I think in trying to address a multiple risk behavior in 30 minutes, The emphasis was placed really on what was more salient for them in their minds, and we see more effects on their violence. The therapist group did decrease violence consequences. Over 16 minutes. In a cost analysis of Safer Teens that we published in Pediatrics, we found that if we implemented this in a separate health system over a 5-year period, we would have averted over 4,000 violent events, consequences prevented at less than $55 per event. This doesn't even take it, it's a very conservative estimate that doesn't even account for if one kid had wound up in the ICU because of a severe crash or a severe event for violence. These estimates would be even much better than this. A tetanus shot costs $129. So we feel that this is cost effective. So what did we learn from Safer Teens before we move on? We learned that a single session can impact violence intervention, can impact violence in the life of teens coming into the ED who present for any cause if they've had some violence in their lives recently. We found that a brief intervention delivered by either a therapist or a computer can have some impact on alcohol consequences, and that we learned both anecdotally and from I think our data telling us that using the computers both for the screening as well as to augment the therapist really was important at having the therapist's effects that we found. But it's short, and are these really real? Did it work? When we think back to why we think that we could have had these effects with this intervention, we come back to a couple different things. One, the strict fidelity, again, because of the computer-assisted format, and that we have fighting is really very highly relevant to the youth's lives in this context. And there's few settings, if any, that anybody is sitting youth down and having a one-to-one, non-judgmental conversation with them about their fighting behavior. And we think that this is one of the reasons this worked. Of course, we never really believe it works until we replicate it. So we replicated it in a recent project, which is now in review, Project Sync. And in this case, we wanted to see whether we could pull off the screening criteria and take it to a universal population. We know all the kids in this neighborhood, in this high-risk hospital that we're involved with, that the neighborhoods have a lot of violence going on. So we gave it to then every youth in that age group who came in just the therapist intervention, and we replicated the findings both for increasing self-efficacy for non-fighting and decreasing the frequency of violent aggression, both for peer and partners. And this data we have just from the last couple months. So we're feeling increasingly confident that this single session intervention indeed had impacts. Talking briefly about UConnect now, moving on from what we have learned about the e-health intervention with Safer Teens, what could we do with computers alone for alcohol? Can we improve the results that we find? We move on to a suburban setting where we have youth that are less involved with violence but more involved with alcohol. And see if we can both replicate these results, but also create an intervention that may be more powerful. Technology has moved on now. It's 5 years later. We can do a little bit better for a computer intervention. We took youth that were 14 to 20 years old. Again, this is underage illegal drinking in the United States, who have an audit score, are slightly more involved in alcohol, with audit scores of greater than 3 or greater than 4 by age. We had over 4,000 complete a screen and divided them into groups of about 200 each. Computer alone, computer assisted by therapists, and enhanced usual care. We developed a new template and format with a newer iPad, laptop technology with touchscreen, a little bit more engaging for the kids. Continued this computerized screening format. We added a theoretical question in here. This is a 3x2 factorial design. We wanted to know, and I was talking to somebody about this briefly after the session yesterday. So this is the ED component, but then what do we have to do after the ED? Can we do a booster session? Should we do a booster session? It's hard to find the kids after. It takes resources to hunt them down. But if it really mattered, then it's probably worth it. So we looked at a fully cross design to get at really, I'm most interested in these two. Can we do a computer intervention with nothing after? Or could we do a control if we miss the kids in the ED and do something with them after, and have those work? As well as if you had to talk to a therapist once, if you talk to them again a few months later, is that really going to improve it, or have you made all the change in this population you're going to make, and you've then lost your not worth the resources spent here? The intervention components are similar to in the last one with an MI focus. Again, benefits of drinking less, harm reduction strategies here, personal strengths, better things to do, very much of a positive spin for youth. Discussion of risky situations, tools for how to stay out of tricky situations if they decide to reduce their drinking. We had a focus section on drinking and driving or riding with an intoxicated driver, and then a final summary screen. Again, I'll point out here it was computer-assisted intervention with the therapist. So for example, here, these questions, here we asked you a bunch of questions about your drinking earlier. Would it be okay if we talked a little bit about this? This is the screen the therapist only is seeing. So the therapist has the screen in front of them. They're talking to the youth in front of them, and it's being fed back to them the answers they have here. This allows the conversation to happen in 35 or 40 minutes instead of an hour. It trims it down a little bit. Again, they have a screen where they can turn, the therapist will turn the computer towards the youth, and they will choose these things together, or if they are doing it on their own, they will pick them individually, and they will go through and pick what are the reasons that I might want to choose to avoid drinking or using drugs. I'll go through and select the ones that are most important to me. These will then be fed back to them in the summary, in the auto-generated summary at the end by the computer, as well as put in front of the therapist later to prompt them to help remember the things that they said to make it more salient to them along the way. This is an example of that summary screen, the things that I would like to avoid, and here it is fed back to the therapist. These are the activities that I said that I would do to help me, that I could do instead of drinking to have fun. And I'm going to play you, I think you have time for this clip. It's 1 minute long. Clips sometimes feel like ever, but I think it's fun to see a little bit. This is the computer clip. It is a condensed version of a 35-minute intervention highlighting just the sections along the way of the standalone computer intervention.
To get started, we're going to have you choose a profile picture. Pick a picture that will represent you for today by dragging it over to the Me box.
Develop this the next time.
Then pick a top friend who will guide you through the activities today.
Earlier, you shared the 5 things that are most important to you right now. How important are each of these goals to you? Now, let's see how your drinking compares to others your age, okay? If you had to guess, what percentage of people your age do you think drink alcohol? Slide the marker over to the percentage you think is correct. Maybe you or someone you know has had a bad experience because of drinking. Each album represents a different area of your life that alcohol can affect. You'll see a list of common problems people experience under each album. Take a look at each album and choose which problems you'd like to avoid in the future. If you decided to drink less or stop drinking completely, it may be hard to follow through in certain situations. This quiz might be helpful to recognize the challenges you might encounter if you choose to drink less. Right now, which of the following statements describes how you are feeling towards drinking?
We're going to have you choose
What might be the next
profile
step for
picture.
you?
Pick
Well, you
a
may or may
picture
not be
that will
ready to
represent
drink
you
less
for
or not
today
at all.
by dragging
You
it
did a
over
great
to
job of
Me
thinking
box.
through some problems you'd like to
Then
avoid
pick
related
a
to
top
drinking.
friend
This is the
who
summary
will guide you
It
through
sounds
the
like for
activities.
you, there are certain situations that could be challenging in the future and put you at risk for some of the things you'd like to avoid.
So you can see it's interactive, it creates a summary, and then along the way the technology improved a lot from the Safer Teens intervention. So now we have the software folks were able to make like drag and drop little things, and when they dragged it over, like here, if the kids picked something with their finger and dragged it over, it like spun around a little bit and dropped in, and it was a little bit more engaging for the teenager. We're not video games. We're never going to be that cool, and so we're never going to be that engaging or that interactive. But you try to do something a little bit to kind of keep them going. What did we think of it in the end? The computer lasted about 35 minutes. The therapist lasted about 45 minutes. Speaking to what we were talking about yesterday, so these are teenagers. Teenagers don't like anything. They didn't hate it, which is great. 75% of they thought the CBI, they liked it. They thought it was okay. They didn't hate it. They liked talking to the therapist. Generally, that was good. But this is practically raving praise from a 15-year-old. So what did we find? Well, we found we improved some from the Safer Teens intervention, although again, different population entirely. So alcohol use was decreased at 3 months in both the computer and the therapist groups. Alcohol consequences was decreased at 3 months in both the computer and the therapist group, and this time we sustained that change to 12 months. The computer intervention, which had a module which I think they spent more time on than the therapist did, also specifically attenuated DUI at 12 months. We also found in looking at that 3x2 factorial design that with the focus question being, do we need a booster session after? And is it worth it to have a booster session after? And we found that the additional session, if you'd had a therapist or a computer intervention in the ED, didn't add anything. But if you hadn't had a session in the ED, then the therapist session after at 3 months helped. So then it's a question of where to put your resources and whether we should be putting our resources into what we should do with the kids while they're there, or if it's impossible to get them there, then to be calling them after and doing a session with them after. The session we did after, we did with them in person whenever possible. Our effect size are modest. This is a brief intervention, folks. What can we expect? It's 30 minutes, right? They're modest. They're in the range of what other brief interventions are. However, I can put a computer in front of a kid for 30 minutes while they're getting other stuff done. This is widely generalizable. And if we can impact things a little bit with changes here in the computer and therapist sustained up to 12 months, effect sizes here, again, modest, 0.1. But are these clinically meaningful? Well, about a 10% different in alcohol consequences. So we changed alcohol consequences over the year at about 10%. Is that clinically significant for a 30-minute intervention? I think so. I think that's probably going to be worth the cost. We haven't done the cost analysis on this, but I think it's promising. What are we going to do with it next? We're looking to, once again, replicate it. I never believe anything we do once in 8 EDs in a geographically dispersed area across the United States. I think it's ripe, especially the computer intervention, probably for some other settings. There's no reason it perhaps couldn't work in primary care or in school settings, and I think those are open to be evaluated. So in the few minutes that I have left, I want to talk just a little bit about changing with technology. From the original very heavy 50-pound computer that my colleagues started with in 1999. We need to think, as we think about e-health, that it moves really quickly. And this was said also yesterday in the e-health session. By the time you develop an app and you do an RCT on it, 3 upgrades have happened later and you can't evaluate it. By the time we published to Safer Teens, our initial findings in JAMA, I couldn't open the program on the computer anymore. In order to replicate it for Project Sync, we had to pay software folks a ton of money to extract it and redo it in a new format because the software was way done by then. 5-6 years later, think of what you were using 6 years ago now. So it gets outdated quickly. This is a real challenge for us in e-health. But on the other hand, there's augments that come along all the time. We didn't have SMS when we were doing Safer Teens either. In the original time, now we have app capabilities. With these come a whole slew of confidentiality, privacy, and copyright problems. Now we have GPS that we can put on the apps to track where they're drinking. Problem, now we know where they're drinking. So there's all kinds of privacy and IRB disaster issues there. I'm going to spend just my brief minute and a half or so left here talking about implementation. If we can't get the research to practice and actually to the bedside, then we're not doing anything right. We talked about this barrier slide before, and I would say we don't fix all of these barriers by e-health by any stretch. We still have to have someone give them the iPad and the screen. The nurses still look at me like I'm crazy when I tell them that they're going to screen a kid who came in with belly pain for violence. So this takes still some moving along a continuum to get clinical care to do this. They have other responsibilities. If we found the therapist worked really well for a brief violence intervention, that's great. Who's going to do that still in my acute care setting? I still have one social worker. How are we going to move this along? So it doesn't move all the barriers completely. To address these, we're working on Safer Teens 2.0 to try to do an implementation study to move Safer Teens to clinical care. We found for Safer Teens, we had effect sizes that were actually a little better than UConnect at 0.27. We know when we move these to clinical care, they will dissipate. So what can we do to augment that? One solution that we've moved to is we now have SMS and text messaging that we didn't have when Safer Teens was originally done. And we are adding augments, so they get an initial session in the ED, and now after, for 2 months, I'll show you in a minute, they get text messages that are pre-fed from their goals and their things that they put in their original format are fed them back to queue them over the next 2 months. Automated, nobody has to do a thing after they leave the ED, it happens automatically. They're both push and pull messages. So again, it's a journey to implementation from the practice. We've created an implementation website that I'll show you in a minute, where we now, when we have hospitals that say, Safer Teens is great, we want Safer Teens. And I say, well, it's a computer program and you have to teach your therapist how to use it and it's simple, and how are you going to roll this out? How are we going to scale it up? And that's where we're at right now. We have an implementation study that's going on to try to get at some of the implementation barriers and challenges, in which we have one arm where the nurse that I've now talked into having an iPad do one question, that's all they're going to do on the iPad, have the kid do one question. If it screens positive, then now we have staff that we've trained with in our implementation manuals on site to give the brief intervention, that will be followed by text messaging. There's some days where the hospitals and our focus groups tell us they're not going to have any staff that's going to be trained to deliver that, so what can we do with them? We're working on a remote therapy or call center telehealth option where the kid will sit in their bedside, and after they get their one question and they screen positive from the nurse, they will then be Skyped in the therapist from our central location to deliver it remotely. We don't know if that works yet. We'll get back to you on that. This is the website, which we will go live in 2016, where you will be able to get all the materials you need to implement Safer Teens. And I'll just spend one last minute on the SMS ending part, which we're in the middle of evaluating, but I think is just so cool, is the kids now get, in month 1, they get three text messages a day. They get an assessment message here. Based on their assessment message, it's pre-programmed to give them feedback on how they're doing. Tailored, again, theoretically grounded text messages. So we can't move to a new platform unless we have a theory behind it. Goals, benefits, tools, strengths, with the thought of the day after that. They get this is an example of this. These are push messages. We now have both push and pull messages available for SMS. So these are push messages, which they get daily, 3 times a day. If they don't answer, it's pre-programmed a certain time later, they will get a different stock message. They are tailored to their goals and their dreams and their strengths and their benefits from their initial session. And then at the end, they get a thought of the day that's, again, tailored for what we know about them. They also have the ability to pull messages. In our focus groups, the kids said to us, well, it doesn't seem like there's anybody there, and what am I going to do? I want to be able to reach out sometime, and we can't staff it right now to have anybody reach out to have live chatting. Maybe something that's not what we have right now, but instead we came up with, if they want some thoughts on how to chill, they can type in chill, and they'll get push messages. That they can pull them back. Well, they'll give them some strategies that they can walk through, and we focus tested these. If they want a plan, they think they're going to have a hard day for something, we gave them some plan messages that we focus tested with them as well. So in conclusion, we have a lot of work over the last 15 years thinking about fast-paced settings. I think we can do brief interventions in fast-paced clinical settings. I think we should. I think we have to figure out how to use the technology in a theoretically grounded way. Alcohol and violence together can be addressed and should be addressed. We also can address alcohol separately, and I think we really must. And I think as we do so and figure out whatever the next thing is after the next app and the next SMS, we have to continue to tie what we know to theory about this. And I'll pause there, and I realized as I was putting this together, this is a stock slide that I've used for years, but I really think it came from a colleague of mine who worked in Australia, because the beaches here are so beautiful. So thank you.